That's a hot topic of the current season. It's a cocktail, an elixir or life. Sorry, an elixir to life. Cocktail, an elixir to life. That's a relevant question which is being discussed. And for this, we have panel discussion with the eminent panelist. And the session will be chaired by the moderator, Dr. Sheetal Binu, who is a senior consultant in medicine at Sunrise Hospital, Kochi. I invite Dr. Sheetal to kindly take over the chair.
Thank you, Dr. Radhakrishnan, sir. I'm very proud to introduce today's panelists and the speaker for the next session from Sunrise Hospital. Dr. Suraj P.Haridas, who is a consultant physician, will be speaking today. He is a consultant physician in Sunrise Hospital. He is an enthusiastic and eloquent speaker, as you will notice today. The panelists, I would like to say each one of the panelists are clinicians who are treating COVID patients, and they have experience with monoclonal antibodies, specifically the casirivimab and imdevimab combination that is called as the antibody cocktail. And that's the reason why they are here, so that they can share their experiences with you all. With that, I would like to introduce them. The first panelist is Dr. Praveen, who is a diabetologist. Yes, he's a diabetologist, and he offered his services for the COVID treatment when our hospital was overwhelmed with patients. So thank you, Dr. Praveen, for joining us here today.
Thank you.
The next panelist is Dr. Vineeth Alexander. He is I think he's a familiar face. He is the pulmonologist from Sunrise Hospital. He's also a nodal officer. So pretty much a lot of responsibilities on his shoulder. Thank you, Dr. Vineeth, for sparing time and coming for this panel discussion. Next panelist is Dr. Jithin Jose, who is the consultant in critical care medicine, and he's the backbone of our critical care at Sunrise. Also, he has just recovered from COVID, and we are so glad and happy to have him back. Welcome, Dr. Jithin. And last but not the least, Dr. Menon. She is a young consultant from Sunrise Hospital, and she is very enthusiastic to share her views today and contribute to the panel discussion. With that, I would hand over I would tell Dr. Suraj to start the discussion.
So good evening, ladies and gentlemen. Thank you, Dr. Sheetal, for that very nice introduction. Thank you, Radhakrishnan, sir. Nice to meet all my lot of good friends, Dr. Suraj, joining us. So hi to everyone. So a hot topic, as mentioned, cocktail. And can cocktails be an elixir to life? So why not we'll have a look at it. So this is a case series on the antibody cocktail that's available and available to our disposal is casirivimab and imdevimab 600 milligram plus 600 milligram as a single dose IV infusion. And this was a case series from Sunrise Hospital, Kochi. And I'll be highlighting 5 case scenarios here and then leave it for our discussion. First patient is Mr. Soman. Now all the names are pseudonyms. Soman, 68-year-old male, is a known case of renal cell carcinoma with surgical procedure, nephrectomy done, unvaccinated, low OT requirement. Date of positivity was July 1st, date of symptom onset July 3rd. That's because he was tested along with his family members, and the date of administration of a antibody cocktail was over the present category of our medications, the standard of care, and above that, the antibody cocktail was given on day 7. And let's see what happened. On day 0, that's mentioning the date just prior to the administration. We had a CRP of 15, and on day 1, that's the very next day after administration, the CRP had plummeted down to 7. Ferritin came down from 582 to 300, total count from 2000, and a marginal raise to 3000 in rather an improvement. How about the clinical parameters? Dyspnea certainly decreased, OT requirement certainly decreased, general condition improved, there were no adverse events. The next patient is Venetian 55-year-old male who was planned for a CABG for a triple vessel disease. He is again unvaccinated with a low OT requirement. Date of positivity was July 4, date of symptom onset July 2. And as soon as he was having such a plethora of comorbidities, he was administered on the day it was detected. So day of administration, day 2. Let's see what happened to him. CRP came down from 1.7. So it's a marginal, mind you, it's a marginal increase in CRP. It came down to 1.3. Ferritin from 236 to 190. So that's a good drop. Total count improved from 3,000 to 6,000. So that's good. ESR went up a little bit from 41 to 60. But the significant thing that you can note over here is the length of stay was only 5 days. Clinical parameters, dyspnea decrease, oxygen requirement decrease, gel conditions certainly improved, and adverse events, none. The next patient is Miss Sheharban, 47-year-old female with recurrent pneumothorax, had a thoracic procedure by Dr. Nasser Youssef 3 weeks prior. She was had a routine follow-up. She was tested positive on July 6th. That was the day when she had symptom of fever, and day of administration, July 8th. That's 2 days later. And let's see what happened. The clinical parameters, dyspnea, oxygen requirement drastically reduced. General conditions certainly improved. Again, no adverse events. The metrics that we looked at, the CRP reduced by close to 50% from 20 to 11. The ferritin from 91 to 70, total count from 6,000 to a marginal drop to 6,100. ESR went down from 70 to 65. The next patient, Mr. Binu, 30-year-old male, young patient, mind you, it's a young, diabetic, obese patient with elevated liver enzymes, mild elevation of liver enzymes, I would rather note, unvaccinated with low O2 requirement. Day of administration was on day 7. So that is the latest that we did. And the clinical parameters observed, dyspnea and oxygen requirement definitely decreased. General condition improved, no adverse events. And the metrics, CRP reduced from 27 to more than 50% on day 1, that's to 10. Ferritin from 972 to drop to 700. Total count again reduced similarly. ESR marginal reduction. Now this is another lady, Shobana, 57-year-old female, uncontrolled diabetic with a diabetic foot and anemia of 8.3, uncontrolled diabetic, A1C 14.9, unvaccinated with low O2 requirement. This is a CT on admission, just showing marginals. There's basically nothing in the CT. Day of administration, day 3. So it was given as early as possible. What did we see? Dyspnea, oxygen requirement certainly decreased. General condition definitely improved. Adverse events, none. Length of stay significantly reduced for a person with so many comorbidities. CRP came down from 110 to close to 50% reduction at 65. Ferritin 255, a marginal increase. So that was not consistent in our case series. Total count 4,000 to 5,000. So that's an improvement. ESR, a marginal increase, but symptoms reduced. Biju, TG, 44-year-old male, alcoholic, liver disease with a hepatocellular carcinoma on chemo, sofosbuvir, worsening jaundice, unvaccinated, low O2 requirement, day of administration, day 5, having been on chemo, we went in early. Let's see what happened. Again, same result. Dyspnea, O2 requirement definitely decreased. General condition improved. Adverse events, none. How about the CRP and ferritin? Definitely both of them reduced significantly. Total count reduced. ESR remained almost the same. Now, what stood apart in this case series? 3 things that was notable and outstanding was the symptomatic relief that the patients obtained. O2 requirements never increased, at least, if not decreased. Inflammatory markers improved early. Now, this is CRP. What specifically was what stood out was immediately after the day of administration, we had at least close to 50% reduction in the CRP levels was observed. Now, other observations made were length of stay was in concordant with the recovery trial, which stated that approximate reduction of the length of stay in hospital was 4 to 5 days, which we observed for all the comorbidities. We would have expected an extended stay, but we had at least 4 to 5 days less, and certainly the mortality benefit was certainly observed. Now, other observations, there was a plummeting of the CRP on the day after, which I mentioned right now. Oxygen requirement drastically reduced, at least close to 50%. The decrease was irrespective of other comorbidities. The decrease was not linked to any radiological improvement, which we obviously didn't expect. Even when the symptom delay was up to 10 days post-symptoms, the benefit was certain. So up to 10 days post-symptoms. That's the same what the recovery trial says. The maximum is 10 days. There is a limit of which we could give the antibody cocktail after symptom onset. However, we wouldn't give them to any patient with high O2 requirement or an NIV or a high con mass. We wouldn't give. The dose that was administered was 600 plus 600 from the original recovery trial, which stated 4 gram plus 4 gram. But here we had it 600 plus 600, which was an approved combination. Now, what are the things to ponder now having seen? And so let's look at it. So dialysis and chemotherapy patients, why not we go ahead and administer early? So find out the people with comorbidities, and is comorbidities are more, and if the unvaccinated, certainly, please, I think this, if we have an excellent option over here, then we have, this has to percolate in the society as well as our fraternity to choose when and where to use. Then our inertia to initiation should also, we should loosen the grip on it. Cost is a deterrent. Definitely cost is a deterrent, because it costs close to 60,000 rupees for this particular dose. And then does it act on variants? Let's see. How about sharing of vials? Now it comes in 1,200 plus 1,200. So you need a partner patient to really administer it. So that's another thing. Future avenues, how about taking this as an opiate? Now, we have seen most of the people we have administered early, and maybe people in, with such comorbidities very well may not have been present to our clinical setup. So why not identify and just at least just we should be aware that there is an OPD injection that can be available. So this can be given in as a subcutaneous route. Now we had an IV infusion, but very well this can be given subcutaneously as well. And also people who are affordable with such comorbidities, certainly it's an option. And then maximum time 10 days post symptoms, no major adverse events were observed. Symptom onset must be the criteria when we choose it. Now, what's this antibody cocktail? It's basically it gives you passive immunity. So you have a casirivimab and indevimab, both are monoclonal antibodies. So you might be very well thinking, why do we need two? So that is because both of them act on different moieties of the spike protein, and that is why we should. This is to just like antibiotic resistance, we shouldn't have emergence of resistance among this wonder drug. So that's a criteria. And this is the methods of administration. That's one as an IV infusion, as other is a 4 injection around your belly, as subcutaneous injection 2.5 ml. Now let's look briefly into the indications for this monoclonal antibody, especially the casirivimab indevimab. Age more than 60 years, obesity, cardiovascular disease, including hypertension, chronic lung disease, including asthma, type 1 and type 2 diabetes, chronic kidney disease, including dialysis, chronic liver disease. So it's all the major organ disorders, you could definitely go for it. Immunosuppressed people, you can go for it. Even people with HIV, AIDS, sickle cell anemia, thalassemia, prolonged use of immune weakening medications, chemotherapy, these are all candidates whom you can administer really early. And the key is that you have to use it early. You can't delay it. You can't just wait for the symptoms to come. And then if you want most of the time, you would have lost precious time. Now, how about special populations? Pediatric populations, no dose adjustment. And after all, if they're older than 12 and at least 40 kilograms, you can go ahead. Pregnancy and lactation, no dosage adjustment. Renal, no dosage adjustments. Hepatic requirement, yet to be studied though. So, for all the observations that we have observed, why shouldn't it be called an elixir? Thank you. It's all with you for the discussion.
Let me start by asking my first question to Dr. Praveen. The emergency use authorization was obtained for this antibody cocktail was obtained on the basis of the conclusion from the phase 3 trial. I would just like you to tell in short about the conclusion of the phase 3 trial. Dr. Praveen.
Yeah, thank you, Dr. Sheetal. Thank you, Dr. Suraj, for that brilliant presentation of our phase series. Actually, phase 3 trial, almost 9,800 patients have been studied. Of that, around 4,567 patients has given various doses of antibody cocktail. That is around 1,200 milligram, 2,400 milligram, and 8,000 milligram of the cocktail has been given to various numbers of patients. Almost around 250 patients have been given that sort of around 30% of patients each given 1,200 to 2,400 and 8,000. And they are compared with the equal number of patients on placebo. And conclusion was that this region COVID antibody, that is antibody cocktail, was well tolerated and significantly reduced the COVID-19 related hospitalization or all-cause mortality by 70%. That is the interesting thing. That is around 70% reduction in the
hospitalization of the patient when we give the antibody initially itself, when it became positive itself. So it rapidly resolves the symptoms, and reduces the viral load. That was also very interesting, and that will definitely improve the immunocompromised patient from going into a lethal, I mean, into mortality or any other complications, pneumonia or anything like that. So they are escape from going into the lethality of the illness.
Thank you, Dr. Praveen. So basically, phase 3 trial showed us that the mortality reduces by, sorry, the incidence of increase in severity is reduced by almost 70% in high-risk patients who were given antibody cocktail, isn't it?
Yes.
Thank you, Dr. Praveen. My next question is to Dr. Vineeth. Dr. Vineeth? Is Dr. Vineeth there?
Vineeth, mute on. Vineeth.
Hello.
Yeah.
Yeah.
Good evening, Dr. Vineeth. My question to you is whether only unvaccinated patients should receive this vaccine.
There is no such study like it should be received in only unvaccinated. Can you hear me? Hello.
Yes.
Yeah,
Yes, we can.
Thank you, Dr. Sheetal. There is no such study as only unvaccinated people have to receive the antibody cocktail. So in this study, which Dr. Praveen has pointed out in recovery trial, it was given to all patients who was seronegative, seropositive, and there was no.
May I interrupt, Dr. Vineeth? Dr. Praveen was talking about the phase 3 trial. You're now talking about the recovery trial.
Recovery trial.
Okay.
There is no such indication as such, like you have to give only to the unvaccinated population, or there is no effect with vaccination with antibody cocktail.
Okay. Dr. Jithin, would you like to add anything to this? What do the current guidelines say? Dr. Jithin has not joined.
Latest NIH guidelines has come up with, irrespective of the previous vaccination status, we can give antibody cocktail.
Okay. Sorry, we couldn't hear you properly. Can you say that again?
Hello?
Yeah.
NIH guidelines has come up with saying that irrespective of the previous vaccination status, we can give antibody cocktail.
That is to only high-risk individuals, right?
High-risk individuals.
Okay, so
according to the EUA indications.
Okay. If according to the emergency use authorization indications, if the patient is having high risk, then despite the vaccine status, you can give antibody cocktail. That is indicated, right? Is that right, Dr. Vineeth and Dr. Jithin?
Yeah.
Is that?
Can I add to that? Actually,
yes.
The trial was initially conducted on this patients who was not hospitalized. It was emergency use was given for those patients only, those people who was not hospitalized and who was not in oxygen support. Those high-risk individual, which Dr. Suraj has presented already, with obesity, immunosuppressed patient, and multiple chronic
comorbidities.
Comorbid diseases. There was significant reduction, so that they could could reduce the hospitalization, and significant improvement was there in their disease.
Okay.
And it was not related to any vaccine or any other particular antibody titer in the body. Actually.
Okay. So my next question is to Dr. Jithin. Why do the current guidelines advise against the use of antibody cocktail in high flow patients who are on high flow oxygen or who are on ventilator support? What is the reason? Dr. Jithin, can you hear me?
Yes, true. Current guidelines don't recommend antibody cocktail to patients who are hospitalized with oxygen support, either high flow or NIV or this thing. Because as we know more about the pathophysiology of COVID-19 infection, we have an initial viral phase followed by a inflammatory phase. So as we know, the antibody cocktail acts on the spike protein, which prevents virus from entering the cells. So once it has gone into the pro-inflammatory stage, they're unlikely to have an effect on the disease progression. Again, studies has come out with unfavorable risk-benefit factors in giving antibody cocktail to hospitalized patients with auto.
So the audio was not clear, but what I understand is there are adverse effects which are seen in the studies when antibody cocktail is given to patients on high flow oxygen and ventilatory support, and that's the reason why it is contraindicated. Am I right, Dr. Jithin?
Yeah. Yes.
I think I'll just move on to the next question. Why do the current, is it mandatory to check the antibody status of the patient or the neutralizing antibody before giving antibody cocktail? Any of the panelists can answer.
Current guidelines does not recommend any checking of the antibody titers measurement. It is very difficult to obtain accurate antibody titers as of now.
Yeah, I agree that there is logistics issues, because we also tried to find out some place where we could test a neutralizing antibody, but in vain. Whether but none of the guidelines are also recommending the test before giving antibody cocktail, right?
No, can I add to that?
Yes, please,
Yeah,
Dr.
yeah.
Vineeth.
Actually, there is, as you said, there is no specific test we have to. I mean, guidelines saying that we have to test an antibody titer before administration. Even all the patients which we are given in this, what Dr. Suraj presented, we have never assessed the antibody titer, and even in all other hospitals, I feel even my colleagues, they are not doing an antibody titer before administering cocktail actually.
Okay.
The guideline, all the guidelines, all that it says is that it has to be administered immediately once the patient is
Yeah.
positive, or within 7 to 10 days of onset of symptoms.
Right.
Nothing specific is being mentioned.
Yeah, so the guidelines say that within 3 days of test positivity, or within 7 to 10 days of onset of symptoms, you can give antibody cocktail to individuals of high risk. Though all the trials have shown that it is effective only in seronegative patients. But still, in the emergency use authorization criteria, there is no such criteria which mentions that you have to test the serology of the patient before giving antibody cocktail. If the patient is having high risk, and if the patient is antigen positive or RT-PCR positive, you must give antibody cocktail. So, my next question is to Dr. Praveen. Are there any particular precautions we should follow while administering the drug, and are there any side effects to it?
Yeah, Sheetal, actually, it should be administered in the hospital setting. We have to keep the patient under observation for any kind of hypersensitivity reaction or anaphylaxis. So far, we didn't have any side effect in our patients. We have used in more than 30 or 35 patients, but we didn't have any side effect. And also, trials also shows that there are not much side effects or anaphylaxis. No such severe anaphylaxis or anything has been recorded, and also in usage also there won't be much of side effect. But we have to expect something or some anaphylactic reaction, so we have to be careful about giving. We don't need to give any pre-medication or anything like steroids, but we have to keep ready some maybe hydrocortisone injection or anything.
Adrenaline.
Yeah, that is what we have to monitor the patient in the hospital setting, not in the OP basis, not in the clinic. So we have to keep him in a hospital setting, and we can discharge him after 1 or 2 hours.
Right. Thank you. That was pretty much clear. And my next question is to Dr. Meena. Can you give it to pregnant patients?
The these monoclonal antibodies, it should not be withheld from usage in pregnant women with the COVID infection who has high risk for who has any condition that can persist as a risk for for the patient to progress into severe
Severe stage.
provided we understand that the potential benefits of the medicine overweight the potential risk.
Okay. So you should not withheld it on the basis that if it is
The patient
you're saving the life of the patient and the benefits outweigh the risk, then you should explain to the bystanders and give it.
go
So
ahead
there's no definite contraindication because there are no studies to show that it can cause any problem. Yeah. Thank you, Dr. Meena. My next question is to Dr. Suraj. How long does the passive immunity last, and when would you advise the patient to take the next dose of vaccine? Dr.
Sheetal, yes. We generally recommend at least a 90-day gap because this can last up to 90 days. That's what studies have shown. So 90 days is probably the time you're looking at.
Yeah, Dr. Meena, would you want to add something to that?
As per the drugs, if I'm not wrong, they say around 28 days of not so sure. I think it is 3 months, 90 days, and as per the drug is concerned, I think it is 28 days.
Okay, so 3 months time, as is our usual guidelines. That is, if any patient recovers from COVID, you can vaccinate after 3 months. So the same guidelines are with them, right?
Yes.
So my next question is to Dr. Vineeth. Is antibody cocktail effective against the Delta variant, which is the most commonest now in India?
Yeah. Actually, the combination with casirivimab and imdivimab is actually effective against the Delta variant. Even other monoclonal antibodies are studied, that is bamlanivimab and sortrovimab, which is latest one by GSK. So the bamlanivimab doesn't show any, had a decreased effect against Delta variant actually.
By itself.
By itself.
Yeah.
So in combination with atezolizumab, another monoclonal antibody, it has shown some effect, but our monoclonal antibody which we use here, casirivimab and imdivimab, is effective against the variant. And as you know, the new even FDA and European Commission has given approval for, FDA has given approval for the new drug which is used alone, that is sortrovimab.
Okay.
It has shown effective against most of the variants.
Including Delta variant?
Including Delta variant. And the guidelines for using that also is the same as the present cocktail what we are using, only in non-hospitalized patients who are at high risk.
But just like bamlanivimab, which its use alone caused antibody resistance, then this the new drug that you mentioned, which is difficult to pronounce, that one also can because it's not in combination, it can also cause antibody resistance, no?
As
Sooner.
you know, most of the drugs can, even when you use TB drugs alone, it can cause resistance. Same thing can happen. No. But this study is just going on. So we don't know the outcome, what is happening. But FDA has given some approval in emergency use. Okay. So we yet have to wait in the see for the general population how it's going to respond.
Okay. So good. What is the name of the new drug you said?
Sortrovimab.
Sortrovimab. Okay. So we look forward to that. My next question is to Dr. Meena. A very interesting question. Convalescent plasma versus antibody cocktail. Which one is superior in the treatment of COVID and why?
I think I would say definitely monoclonal antibodies because they are monoclonal antibodies because they have more specific antibodies and the dosing will be more precise. Am I audible?
Yeah, a little bit disturbance was there. Now you're audible.
Yeah, I would definitely say it is monoclonal antibodies because they have more specific antibodies against COVID virus, and the dosing will be more precise when compared to convalescent plasma therapy because of higher antibody titers, and it's user friendly, easily available. And there are certain limitations when you compare with there are certain limitations for convalescent plasma therapy, like there is difficulty in collection, uh, chances for cross infections, need for screening prior to administration. There will be variability in the antibody titers.
Yes, yeah, yeah. So, anybody would like to differ? Any of the panelists?
I think this plasma, convalescent therapy, actually, it's out of question now because
Yeah, I know all the
already
guidelines have
government has
taken it out.
taken out from the guidelines. So as of now, we have left with this monoclonal antibody also solely. So, so I think
Yeah,
we have to go ahead with that.
yeah.
Uh,
Bas-
according to the guideline, we have to follow the guidelines and use in the appropriate patients.
yeah. So, like Dr. Meena said, it is more user friendly because
Yeah.
it's available in your pharmacy. You don't have to go to the rigorous process of finding one patient with high, who has recovered from COVID, who has got high titer of antibody, and then see that he does the plasma doesn't have any infection, and then give it at the right time to the right patient.
And
So
and convincing him to do that also.
yes, so it's a rigorous process, and for which you require a very, very well-oiled machinery. So I think this is much easier for the doctors also to prescribe. So coming to that, we'll come to the limitations of the antibody cocktail. Dr. Suraj, Dr. Suraj,
Yes.
the limitations of antibody cocktail
Yes.
of the elixir.
Oh, okay. Now use it early. The timing is very important because if
Sorry. I'm asking you about the limitations.
limitation.
Limitations.
Right. I think I'll let Dr. Vineeth answer that.
Oh, I am so sorry. I was intimidating her. You can take your time. Okay, Dr. Vineeth.
Actually,
I think,
limitation is like we have not got the approval to use in hospitalized patient. Actually, that is one thing. Even if we have used it now, that is most of our cases which we have used is patient who have come with other comorbidities and turned to be positive at testing. And
I think
even
cost
if
also is a matter, no?
cost is definitely a factor because it will cost around 60,000 for one dose, and finding a person spending for 60,000 and telling him you won't go for a severe disease.
Yeah, it is very difficult.
When they are in mild case, when they don't require oxygen support, people will be reluctant to use. It's just a fever. All are recovered. Why should I do that? That will be the attitude of patients, as you know. So in severe, in comorbidities, actually, we have to have some. We have to give some convincing arguments about using it so that the patient won't go to a severe disease. And usually, another problem is getting two patients simultaneously to administer the vial. So the maximum storage time is around 2 to 3 days only. Once you open the vial, I think 2 days only we can use it in another patient. And any hospital will not be willing to sacrifice 60,000 rupees for, just keep the vial in the fridge and then use it afterwards. That won't be happening. So first limitation will be the cost. Second limitation will be the dose. The vial sharing will be a difficult thing. And convincing the patient for taking the antibody cocktail is another thing. And availability of the medicine also will be another thing.
Yeah. Okay. What about antibody resistance?
This
can eventually
Hello, can you? Eventually, antibody resistance, we have not encountered any cases like that. There are chances to get that.
Yeah, as the new mutant variants arrive,
Yeah.
I think there is a chance of antibody resistance also. Okay, so the limitations, as you rightly said, is the cost as well as the sharing within that stipulated time is a big limitation. So my next question is to Dr. Jithin. Do the current just a moment. So once we have given antibody cocktail to a person, and unluckily the patient has worsened and progressed to a severe form of disease, and gone into a cytokine storm, and now he requires tocilizumab. Is there any contraindication in giving it? And since both of them are monoclonal antibodies, do you think there will be some added side effect, Dr. Jithin?
No, as of now, there are no contraindications in giving tocilizumab along with after giving a monoclonal antibody, because as we told, both are even though both are monoclonal antibodies, monoclonal like this region 2 work like protein, whereas tocilizumab is an IL-6 inhibitor. It has different mechanisms of action, so it doesn't interact or doesn't add up any side effects or anything.
Okay.
We safely give tocilizumab. We should give tocilizumab if the patient goes into higher support or worsening.
Dr. Suraj, would you like to add anything to this? Any of the panelists?
We seldom come across such a situation if we are on time. So it's just a hypothetical question as well. So probably we'll have a little more experience, and that might guide us better. Almost most of the patients, if I would say at least 95 plus patients, have had good effect with just the monoclonal antibodies plus standard of care, remdesivir and antibiotics. So, and the length of stay was significantly shortened before. So probably the cytokine storm was averted. So that gives us some
Okay.
space.
Thank you, everyone. And so I think we'll be open to questions now. Yeah, there's a question. What is the exact cost of the administration, including the cost of medicine? So I think Dr. Vineeth already answered that. Dr. Vineeth, would you?
Yeah, the cost of medicine is around 60,000 rupees for a single dose. Like that will be around 600 mg of casirivimab and 600 mg of imdevimab. It will usually comes in 2 vials, that is 1200 mg each in each vial. So the total cost will be around 1,20,000 rupees for 2 vials of 1 vial of casirivimab and 1 vial of imdevimab. So for a single patient, it will cost around 60,000 rupees. And administration charge depends on the hospital, what all things are there.
What?
Okay. Can be given as an IV infusion over 1 hour. So it doesn't add much charge to accept that of medicine. Can be given as a OP in OP basis also.
No, just remove this, no?
May I ask a question?
Yes, sir, please.
In fact, you mentioned that. Am I audible?
Sir, there is an echo there. I don't know.
Take the headphone off. There's echo.
I don't have a headphone.
No, the person who's speaking, tell him if he takes off the headphone.
Am I audible now?
Yes, sir.
Yeah, in fact, just one question. Like you have used for patients inside the hospital, and as I understand, it is approved for mild to moderate diseases with multiple comorbidities. So, are our guidelines mentioning that it can be used in Indian setup in the hospital, or do you feel that it's high time that we change the guidelines, or did you use it under a trial protocol?
Sir, what we have used as Dr. Suraj has presented here, Dr. Suraj has used. So that was the patients who received the drug was all the comorbidities patients who has come for other disease mostly and have turned positive. So they were invariably was about to get admitted for other reasons. So we have to give the drug actually. So for mostly the guidelines, what Indian scenario it is approved is for patients who are not hospitalized.
Okay.
Not only in Indian, everywhere in the world it is.
In the world, yeah, FDA approval even it's for only.
It is not an recommended drug. It is for the emergency. It's only for the emergency usage. It is approved everywhere.
But may I submit one thing? You mentioned about the recovery trial, where it was given to patients who are hospitalized. Am I right? In the recovery trial.
Yeah.
Yeah. That is for the study purpose. They have admitted.
Okay. So in the wake of that study, probably the guidelines also might change, right?
Yeah. Definitely.
Yeah,
it will come year. It will definitely change.
All right. Thank you.
Am I audible?
Um,
Hello. Am I audible?
Not yet. I think you're muted. Dr. Prasanna, you're muted. Yeah.
Hear me now? Can you hear me now?
Yeah.
yes, sir. Yes, sir. We can hear.
Yeah. Just I would like to know in your this experience in your hospital, what percentage of cases in which you have given this have you have seen good success? What's the percentage of cases in which you have given this you have seen better success and good success?
Sheetal, can I answer that?
Yeah, sure.
Yeah, Prasanna sir, majority of our patients have a very good progress actually. Actually, one of my patient has a bad experience because that patient was having a carcinoma lung and he was on chemotherapy and all, and that is why we, after second day itself, we have given him the antibody cocktail in view of worsening of the symptoms. But in spite of that, he worsened not because of the antibody cocktail, because of the other illness he was having. And the family members also are expecting he is in a palliative care actually. And when only and that patient we have a bad experience. All other patients doesn't have. They improved a lot, and they improved. And also the stay was very less, around 3 to 5 days was the hospital stay for all our patients. So I think for Dr. Meena, any untoward happened in your patients?
Nothing.
Only this patient has a problem. And first of our patient was an CLL, ALL patient, acute lymphoid leukemia patient, and he was on remission actually. And that patient improved a lot because he was worsening like anything. The third day he developed breathing difficulty, and we have given him antibody cocktail on the fourth day after convincing them. So that patient improved, and he was discharged because of his comorbidities. He have a long stay in the hospital because of other complications. Yeah, and he is discharged healthy. Okay, thank you.
Thank you, Dr. Sheetal. I suppose we can wind up the session now.
Yes, sir.
Yeah. Thank you, Dr. Sheetal, and all the panelists for such an informative discussion. One of the major emerging therapies in treating COVID-19. Thank you, all of you. Now let us move to the next part of today's meet. May I invite Dr. Sumesh from APA Kochi to kindly give the word of thanks. Yeah. Dr. Sumesh, please.
Yeah, am I audible? Yeah. It's my honor to give the vote of thanks. First of all, on behalf of APA Kochi, let me give a heartfelt thanks to Dr. Jithin Jose for accepting our invitation and giving a wonderful exposition on dapagliflozin. Thank you, sir, once again. Sincere gratitude to our dear friend, Dr. Vineeth Chandran, for sharing the session and for the sharing of his knowledge and experience. A big thanks to Dr. Suraj Haridas for its wonderful presentation of the practical cases which highlighted the use of the new monoclonal antibody cocktail in the management of COVID-19. I give my thanks to our panelists, Dr. Praveen, Dr. Meena Menon, Dr. Jithin Jose, and Dr. Vineeth, for having spared their time and giving their valuable inputs during the discussion. These discussions were ably moderated and kept to the point and time by our APA Secretary, Dr. Sheetal Binu. Thank you, ma'am, once again. Thank you, everybody, once again, to the entire team from Sunrise Hospital for giving us a hands-on experience on the use of monoclonal antibody cocktail, which is a new weapon in the armamentarium against COVID-19. It was a wonderful experience and a wonderful learning for all of us here. Thank you, thank you for the Sunrise team once again. Thanks to Mr. Shivakumar and his team from JB Chemicals, who has been always with us in helping us to organize the various APA events. Thanks to Arun Moses and the IT guys for the smooth operation of today's online gaming, which went about without a glitch. And most importantly, thanks to each and every participant for sparing your precious time in attending today's online CME. Hope you would have gained from your time well spent. Thank you, everybody, once again, and have a very good night. I hand over the session to our chairperson, Dr. Radhakrishnan, for the concluding remarks. Over to you, sir.
Thank you, Dr. Sumesh. It was indeed a wonderful evening for all of us. A lot of very useful information which can be put into our daily practice and caring of the patients. So without much ado, let us conclude today. Good night to everybody. Good night.
Good night, sir.
Good night.